All right, let's dive right in. Today, we're going to unpack a really fascinating group of kidney diseases. On the surface, they can look pretty different, but they're all connected by a defect in one tiny, elegant cellular structure. We're going to be looking at the major hereditary cystic kidney diseases, but we'll be framing them through the modern and incredibly powerful concept of ciliopathies.
So here's our game plan. We'll kick things off by establishing the ciliopathy framework. What does that term even mean? Then, we'll spend a good chunk of our time on the big one, autosomal dominant polycystic kidney disease, or ADPKD. We'll cover its genetics, diagnosis, management, the whole deal. From there, we'll contrast ADPKD with the other important ciliopathies. We'll also talk about a key imposter condition you need to know about, and then we'll wrap it all up with a rapid-fire review to make sure the most critical facts really stick.
So, what exactly is a ciliopathy? This right here is the central dogma. It's a genetic disorder, and the root cause is a problem with the primary cilia. Now, you can think of these as tiny, hair-like antennas on the surface of our kidney tubule cells. Their job is to sense flow and chemical signals, basically telling the cells how to behave. When these cilia are defective, the cells lose that crucial signal. They lose their differentiated phenotype, they forget what they're supposed to be doing, and that confusion leads directly to the uncontrolled proliferation that forms cysts. This is the unifying mechanism.
Okay, with that framework established, let's turn our attention to the quintessential ciliopathy, the one you'll see most often, autosomal dominant polycystic kidney disease. Let's start at the beginning, with its genetics and how we make the diagnosis. This table breaks down the genetics beautifully. You can see right away that the lion's share of cases, about 85%, are due to a mutation in the PKD1 gene on chromosome 16. This gene codes for a protein called polycystin-1. And this is clinically huge because PKD1 mutations are associated with a more severe, more rapidly progressive disease. The other 15% or so are typically caused by mutations in the PKD2 gene on chromosome 4, which codes for polycystin-2 and usually results in a milder disease course. And just for completeness, there's a very rare form, sometimes called PKD3, linked to the GAN-AB gene.
Now here is a clinical pearl you absolutely cannot forget. Even though this is an autosomal dominant disease, about 1 in 10 cases arises from a brand new, spontaneous mutation. What this means in practice is that you can't rule out ADPKD just because the patient says, "No one in my family has ever had this." The absence of a family history does not exclude the diagnosis.
So how do we diagnose it? The workhorse is renal ultrasound. But here's the key. You have to use age-stratified criteria, often called the Ravine criteria. Why? Because everybody develops a few simple cysts as they get older. We have to set the bar differently for different age groups to be accurate. For the youngest at-risk people, that bar is actually quite low.
So let's get specific. If you have an at-risk individual who is between the ages of 15 and 39, all you need to see on ultrasound is a total of 3 or more cysts. It doesn't matter if they're all in one kidney or spread between the two. 3 is the magic number for this age group.
Now watch what happens as people get older. For the 40 to 59 age group, the criteria gets stricter. You now need to see at least 2 cysts in each kidney. And for those over age 60, the bar is even higher, at least 4 cysts in each kidney. This progressive increase in the required cyst burden is absolutely critical to avoid overdiagnosing the condition in people with age-related simple cysts.
But what if you need to rule the disease out? This is a really high-stakes question, especially for a family member who wants to be a living kidney donor. In that scenario, an ultrasound just isn't sensitive enough. We turn to MRI. And the key takeaway is this. For an at-risk individual, a completely clean abdominal MRI by age 30 provides incredibly strong reassurance that they did not inherit the gene and won't develop the disease.
Okay, so we know the genetics and we know how to make the diagnosis. Now let's pivot to the clinical side of things. How do patients with ADPKD actually present? What factors predict their future? And what can we do to manage the disease?
You know, a lot of patients are actually discovered by accident, completely asymptomatic on a scan for something else. But the most common symptom is abdominal discomfort or pain, just from the sheer size of the kidneys. We call that renomegaly. A really critical presentation is severe hypertension, which can show up early and already have caused end organ damage. Another clue is tubular dysfunction. Patients complain of having to urinate all the time, especially at night, because their kidneys can't concentrate urine properly. And here's a classic board question tidbit. Of all the causes of chronic kidney disease, ADPKD is the one that's least likely to cause anemia, because erythropoietin production from the cystic tissue is often preserved or even increased.
So who's going to do poorly? Well, there are several red flags. Being a black male, getting diagnosed before age 30, or developing hypertension before 35 are all bad signs. Genetically, a specific type of PKD1 mutation called a truncating mutation predicts a much tougher course. But the single best, most powerful predictor we have for how fast this disease will progress is the total kidney volume measured precisely on an MRI. Bigger kidneys mean faster progression.
When a patient with ADPKD comes in with sudden, severe abdominal pain, you need to be thinking. It could be a cyst bleed, a stone, or an infection. If it's a cyst infection, the #1 bug is E. coli. The challenge is getting antibiotics into the cyst, so you need drugs with good penetration. Think ciprofloxacin, cotrimoxazole, or carbapenium. If you're thinking it's a kidney stone, remember this key difference. In ADPKD patients, uric acid stones are actually more common than the typical calcium oxalate stones.
So, how do we fight back? There are 4 main pillars of management. First, and arguably most important, is aggressive blood pressure control, usually with an ACE inhibitor or an ARB. Second, you push fluids, and I mean a lot, like 4 to 5 liters a day. The goal here is to suppress vasopressin, or ADH, a hormone that's a major driver of cyst growth. Third, to prevent those uric acid stones, we use potassium citrate. And finally, we have our targeted therapy, tolvaptan. It's a V2 receptor antagonist that can slow disease progression, but it comes with the risk of liver toxicity, so you have to monitor liver function tests very closely. It's so important to remember that ADPKD isn't just a kidney disease. It's a systemic disorder. By far the most common issue outside the kidneys is liver cysts, but you also see a higher risk of brain aneurysms, which can be devastating. Other associations include colonic diverticula, mitral valve prolapse, and various hernias. This is all part of the same underlying connective tissue problem caused by the faulty polycystin protein.
Okay, we've got a really solid handle on ADPKD now, so let's broaden our perspective and see how it stacks up against the other major renal ciliopathies. This is all about compare and contrast. This table is absolute gold for keeping these straight. You see ADPKD up top, dominant, big kidneys, adult onset. Now look at autosomal recessive PKD, or ARPKD. It's a disease of newborns, also with enlarged kidneys, but its key feature is congenital hepatic fibrosis. Then we have 2 diseases that cause small, shrunken kidneys. Juvenile nephronophthisis, or JNP, is recessive, hits in childhood, and is famously associated with eye problems, specifically retinitis pigmentosa. And then there's medullary cystic kidney disease, or MCKD, which is dominant, presents in young adults, and is linked to high uric acid and gout.
Let's put those last 2 side by side, because they can be tricky. JNP is recessive. It's a disease of kids, leading to kidney failure by the early teens. Clinically, they present with salt wasting and failure to thrive, and that association with retinitis pigmentosa has a name, senior Loken syndrome. MCKD, on the other hand, is dominant. It presents in adulthood and leads to kidney failure later in life. Its hallmark isn't an eye problem, but rather a metabolic one, hyperuricemia and gout, especially with the MCKD2 type, which is a mutation in the uromodulin gene.
Okay, we've covered the major players, but here's a crucial question, both for the clinic and for your exams. There's a common condition out there that can look a lot like these diseases, but it is fundamentally different. It's not a ciliopathy at all. What is it?
And that brings us to our critical exception, the great mimicker medullary sponge kidney. You have to be able to distinguish this from the true ciliopathies because it is not a genetic inherited disease. It's an acquired malformation.
So what does medullary sponge kidney look like? Well, it's a developmental abnormality of the very last part of the kidney tubules. The classic clinical picture is a triad of recurrent kidney stones, recurrent UTIs, and hematuria. The reason for the stones is underlying hypercalciuria and a type of incomplete distal RTA, which leads to calcium phosphate stones. But here's the most important distinction. The prognosis is generally excellent. Overall kidney function usually stays normal. And if you were to see an old-school imaging study, like an excretory urogram, you'd see the classic paintbrush or bouquet of flowers appearance.
All right, we've covered a lot of ground. To finish up, let's do a rapid-fire review and really hammer home the absolute must-know facts for each of these conditions.
Okay, let's lock this in. ADPKD, think chromosome 16 and 4, the polycystin proteins, hypertension, liver cysts, brain aneurysms, and the drug tolvaptan. ARPKD, think chromosome 6, the fibrocystin protein, perinatal onset, pulmonary hypoplasia, and in kids who survive, congenital hepatic fibrosis and portal hypertension. JNP, chromosome 2, nephrocystin, recessive, kidney failure in the teens, and that key association with retinitis pigmentosa and senior Loken syndrome. And finally, MCKD, dominant inheritance, adult-onset kidney failure, and the strong link to the uromodulin protein and gout.
And so we'll end with a thought to take with you. We now have targeted therapies like tolvaptan for ADPKD, and our ability to do genetic testing is exploding. So the question becomes, as we move forward, which of these diseases, whose outcomes we once thought were set in stone, will be the first to have its natural history completely rewritten by medicine? That's the exciting future of this field.